Giuseppe, and I'm here to chair this presentation. And I always think that it's a good idea to see what psychotherapists do. You know, they write a lot about what they do, they do research on what they do, but we don't often get to see them. I think learning by watching people is really a superior way to learn. And so one of the things that students always ask me, or people in presentations, is what's the difference between cognitive therapy and REBT? And Ellis and Tim Beck were kind of friends. They knew each other from the 1960s or maybe earlier. They sort of influenced each other and even shared laughs together. Tim did call himself the father of CBT, and Al had to then call himself the grandfather. So they had sort of a really nice relationship over the years. And so what are the differences between these two approaches? Somebody once said to me, Steve Holland, that Tim started to work with people who were depressed, and Al worked with people who mostly had anxiety disorders. Depressed people have thoughts that are past tense, and anxiety disorders have people who thoughts that are future tense, and that sort of influenced them. So let's sort of look at some of the critical components of REBT and cognitive therapy, and then we're going to have our two therapists do a demonstration. Cognitive therapy does a critical component there is the cognitive conceptualization of the case, using thoughts to really identify what's going on. They are more likely, I think, to do a thorough diagnosis, maybe following a medical model, and develop specific interventions and treatments for diagnostic disorders. They focus on a strong therapeutic alliance. They set agendas. They very much have a structured therapy session where they're going to set an agenda, stick by the agenda, give feedback and paraphrase as time goes by. They're going to take a very problem-solving, present orientation. They're going to talk about the evaluation of thoughts and beliefs, examine more negative automatic thoughts. I like to say that the negative automatic thoughts refer to what William James called the stream of consciousness cognitions, and they're going to focus on those. Then they're going to move and identify more underlying schema that may be the cause of these stream of consciousness cognitions. They're going to provide a lot of capsules and summaries as they proceed through the session, and they're going to move on to homework. The critical components of REBT is they're going to deal with presenting problems quickly to promote client remoralization. They're probably less concerned with diagnosis and look at this as a trans-diagnostic approach and want to give clients hope as quickly as possible. They're going to focus more on the beliefs of demandingness, the beliefs that rigid, inflexibly holding on to the idea that the universe is supposed to be the way people want it to be. These may be referred to as schema, and there's a lot of research showing that what the cognitive therapists call underlying schema and irrational beliefs are highly correlated. They're going to then focus on derivative beliefs such as frustration, intolerance, global evaluation of the self or others, I'm no good, he, she is no good, and evaluative beliefs such as things are terrible and awful. They're going to focus more on metacognitive disturbance, that is, sometimes in the ABC model, activating event, belief, and consequences, to see how I feel and behave. It becomes an A, and then I'm going to catastrophize and demand that I not have that. This is kind of equivalent to something that cognitive therapists have done recently that Adrian Wells called metacognitive therapy, but for REBT it's always been one of the primary things that we do. They're going to challenge irrational beliefs, and they're going to encourage rational thoughts, and the rational thoughts that they encourage really come from a Stoic philosophy of life that Albert Ellis has adopted. I would say that Al Ellis was a theoretician about the nature of psychotherapy and psychopathology, a psychotherapist, but also a philosopher of life. And so they propose that. And like cognitive therapy, they're going to negotiate homework. So we're going to see how different or similar these therapies are. So the questions I have for the audience are these forms of psychotherapy different? Are they noticeably different? To use a term from psychophysics, is there a JND, just noticeably different term, an observation between them? Are they more alike than different? Do they really focus on different cognitions and beliefs? Do they both use the same number of common factors that Wampold has identified that seem to be common in all psychotherapies? So we have a client today. The client is Andrew. I know Andrew. Our therapist does know Andrew. He's a 25-year-old graduate student entering his third year in clinical psychology. The description of Andrew he wrote. This is information that he wanted or was okay with sharing with you. And although Andrew has been anxious his entire life, he recently began experiencing acute anxiety regarding his career as his coursework and requirements have become more burdensome, including beginning his externship and a teaching assistant position. His anxiety has worsened. Specifically, his anxiety is related to fears that he will not complete all the weekly tasks he has to do. He recently experienced a minor panic attack while creating his daily schedule for the fall semester. Maybe I should be the therapist then too, for the client. While this is the catalyst for his seeking treatment. Andrew has self-esteem issues related to his anxiety. These issues revolve around the idea that he will not be a good psychotherapist. His self-doubts most commonly occur when reading books about therapy techniques. Recently reading Judith Beck's book on cognitive behavior therapy and Irving Yalom's book, The Gift of Therapy. But he sometimes experiences down swollen sessions with patients and he has his anxiety there. He also becomes anxious while thinking about internship applications, which may be true of all graduate students, and specifically his career path in clinical psychology after that. And Andrew is seeking help to alleviate his anxiety and self-doubts. Okay. Now, what we agreed to do here is each psychotherapist is going to have 30 minutes with Andrew. We've already flipped a coin so that one will go first. Art won the coin toss, and Kristene will not be in the room so that she doesn't have any additional information that would give her an advantage when she becomes a therapist. I will be the timekeeper. It's kind of running like an NFL game, we have a coin toss, timekeeper, and then it will change. When we're done, we really want participation from the audience. We want you to answer questions that we discussed with you beforehand and anything that you would have. We're going to ask Andrew to share his experience of the psychotherapy. What was it like as the client with each of these psychotherapists? And then we're going to open it to the audience for questions. Okay? So let's begin. And here's our psychotherapist. Let me introduce our psychotherapist. I forgot to do that. Art Freeman is let me say two things about our therapist. Both of them are sort of spokesperson for their respective psychotherapists. Both of them have trained people in their respective forms of psychotherapy around the world, so they have lots of international experience and lots of experience applying this to people with different cultures. And so Art Freeman is a native of New York, lived in Philadelphia for many years, worked with Beck's Center for Cognitive Therapy, and now is at Midwestern University outside of Chicago. Kristene Doyle got her PhD from Hofstra. She's a native of Manhattan, and she's a native New Yorker who doesn't like to leave the city whenever possible and avoids things like trees and squirrels. But she studied with Albert Ellis and is now the director of the Albert Ellis Institute. So I know them well, they're both good friends, and I appreciate their getting together for this. So, Andrew and Art, let's take over and I'll watch the clock.
Making sure you got the good side facing the audience?
There's a problem, Andrew. There is no good side. It is what it is, Andrew.
Nice to see you, Art.
Two things. I'm going to take notes while we talk.
Okay.
So I make sure I know what you're saying. And also, I have my watch here. I'll do what I hate to do, which is to be a clock watcher. But I want to keep to our time and use our time as efficiently as I can.
Sure.
Okay?
Okay.
Again, thank you for doing this. As I thought about this, Andrew, it occurred to me how brave you are. It's very courageous to do this. To get up in front of a room full of people, in front of your major professor, to talk to a stranger. I thought, wow, that must be really anxiety provoking,
A little bit.
but not enough to keep you from doing it. You didn't call Dr. Giuseppe and say, Dr. D, I'm sick, I can't do it. Right?
Right.
You're here.
Right.
And you talk about this long history of anxiety. When you say long, Andrew, how far back can you recall being anxious?
My mother tells stories of when I was like 3 and 4 years old and would just pace around the room because I was so anxious. I can't remember having like any real issues with anxiety until I was, I guess it was probably when I moved up to New York. I was born in New Orleans.
Well, let me just- So you paced around the room,
Mm-hmm.
and your mother said you were an anxious kid.
Mm-hmm.
She didn't say you were an ADHD kid.
No.
She said you were anxious. So she labeled this thing.
Right.
Is that right?
Right.
And when she took you to a psychologist, psychiatrist, he confirmed her diagnosis.
No, I never went to a psychologist when I was younger. Well, I did, but it was for issues with having nightmares and revolving around thunderstorms. I would avoid school when there was rain.
So your mother labeled that as part of your anxiety.
Right.
Okay. So your main diagnosis of anxiety comes from your mom.
Right.
Okay. So you have negative reactions to thunderstorms, to rain.
Right.
Take me forward with that. So it goes back to when you're 3 or 4.
Mhm.
How was a teenager? Were you anxious as a teenager?
Yeah, I think so. I went to a pretty intimidating is not the right word, but I went to a really
It's a good word.
it is high school. It was a Jesuit high school.
Ah,
And there was a lot of pressure put on all of us to do well, and I was in honors courses, so there's a little bit of extra internal pressure to do better and to stay on par with my peers.
but you did well.
I did well.
Now, many people, when they get anxious, it interferes with function. And you're saying your anxiety in high school, even in Jesuit school, actually helped you.
It was adaptive, yes.
It was adaptive. And then you pick a Jesuit university, right?
No, I picked a public university. I picked a party school.
Were you anxious there?
I was not. Alcohol helps.
Okay. So undergraduate school was not anxiety provoking.
There were times, I think the biggest times were during junior and senior year when I was thinking about what do I want to do? Do I want to go to law school or do I want to try to pursue graduate school in psychology? So a lot of the anxiety revolved around choosing a career path. And
That sounds pretty normal.
it was I mean, you know, I didn't think too much of it, I guess. There were times when I got extremely anxious, when I would try to find ways to cope, like exercising or doing some type of breathing techniques that I learned through therapy when I was an undergraduate. But
So the alcohol wasn't enough, you had to get therapy too.
right.
Now, my understanding of anxiety, and let me share that with you and get your reaction. What Dr. Giuseppe said, people who are depressed look backwards and talk about what was or wasn't. Anxious people look ahead and think about what's going to happen.
Right.
Is that your experience?
Yes.
And that one of the common schema, having taken courses, Dr. you said you know all about this stuff. One of the common schema for people who are anxious is the world is a dangerous place. Is that your understanding and experience?
No, no, I don't think so.
But things in the future still get you anxious.
They do.
How then did you reconcile, reduce the dissonance between your anxiety and doing this? What allows you to be sitting there?
That's a good question. Sometimes I just kind of push through it, I guess. It's one of those things where I kind of force myself to step outside of a comfort zone to, I don't know if it's like a way to combat my own anxiety or what kind of technique I'm internally.
Counterphobic?
Right. It's something I've always done. I mean, when I moved up here to New York, well, I moved to New York, that was part of that too, is I wanted to step out of a comfort zone and not stay in Louisiana and go to a state school. I forced myself to apply to programs across the country rather than just in the South or at home.
But you also picked a very difficult and competitive program at a very difficult and competitive school, St. John's. You could have picked an easier school,
Sure.
but you didn't.
Right.
So you do put yourself out. But help me understand that. How do you resolve that dissonance? That I'm anxious, I'm afraid things won't go well, won't do a good session, won't be a good psychologist, and let me agree to appear before, 50, 70 people to talk to a stranger. How do you do
I don't know. I feel like a lot of the anxiety that I have comes with like these things that are like more than just a few days away. It's these like extreme future events, like my career. Like what am I going to do for my internship? What do I want to? Do I want to be a therapist? Do I want to do assessment? Do I want to
research?
Do I want to be a neuropsychologist? Do I want to? What, if I be a therapist, what kind of orientation am I going to have? These extremely far away events that are kind of like broad, and like these narrow events like you coming here, this is far less anxiety provoking to me for whatever reason
So
than
you were about broad. How many colleagues in your cohort at St. John's?
there's 9 in my year. There's 9 other ladies and myself.
Okay. Of the 10 of you, we made a list of all the questions you're asking. How many of them would endorse the fact that they also experience questions about this?
Probably a good number of them,
What's your guess?
at least half, if not more.
Half more. 2 more?
I'd say probably about 6 or 7 of them dying outside of me.
We'll include you, so
So 7 or 8.
7 out of 10, so that's 8%.
Right.
We've had research courses, right?
Yes.
80% a lot,
It's pretty good.
significant.
I'd say P is less than 0.05 there.
Dr. D taught you right.
Bill Chaplin taught me right.
I see. So you worry about the big things.
Yes.
You don't sweat the little things.
Or at least the things that I don't see as.
Take any courses on anxiety?
Broad courses on, DSM and stuff like that, so we've gone over anxiety.
What's probably among the most common referrals for treatment of anxiety? Social anxiety specifically.
I'm not sure I'm understanding the question.
Of all the anxiety manifestations, what is one of the most common referrals? You know? I think it's public speaking anxiety.
That sounds about right.
So, public speaking anxiety is very common.
Mhm.
I would guess 80% of the people here would not do what you're doing. That's my guess. But you're able to do it. You're able to do what most people have trouble doing. Right?
Right.
Now, have you totally dissociated and blocked them out?
For the most part, yes.
They're not even here.
No, they're not.
I'm pretty far advanced in my career, as is Dr. D just said. Do you think Dr. D gets anxious before he does a presentation?
I don't know the right answer to that. No, I'm sure he does. I'm sure he does.
That's the right answer. Do you think Dr. Doyle gets anxious before she makes a presentation?
Yes.
I get anxious. So what do you make of that? Here we are, experienced teachers, professors, and we experience anxiety. What do you make of that? How do you process that?
I don't know. I just think sometimes when I'm thinking to myself, I'm thinking like, you should not be experiencing this. This isn't something like, this isn't a big deal kind of thing. Like, just stop having these stupid thoughts, is what I basically tell myself. And just, things are going to end up working out. They always end up
But you know
working out. I
But you
think
still get
that,
anxious.
yes.
And how, again, help me understand the dissonance here. Part of you says, internal dialogue is, Andrew, it's gonna work out, ain't a big deal, right?
Right.
I've done it before. But part of you says, oh my God, oh my God.
Right.
How do you put those two pieces together? How do you make sense of that?
I guess I haven't done that. I guess that's part of the problem.
Let me share a suspicion.
Sure.
I think you're able to do this because you have put it together. And maybe what you haven't done is really looked at how you take two competing pieces and allow yourself to function as well as you do. Have you looked at that?
I'm sure that I have. And I guess when I do that, I choose to just like glance over it and just let it go right by, and I just don't pay any mind to that. I guess probably would rather pay more mind to these sinking feelings of being overwhelmed.
Do these sinking feelings make you feel better?
No, not at all.
Do they make you more adaptive?
No.
They lead to more sinking feelings.
Right.
Silly question, but I have to ask it.
Sure.
And then why do you do it?
Self-defeating prophecy, I guess.
Oh, come on, you gotta do better than that.
Maybe part of me just enjoys trying to force myself to be anxious because I feel like maybe it'll help me perform better since it's helped me in the past somewhat.
Now, that's true.
Right.
There's no question that moderate anxiety helps you succeed, right? But yours, you say, is more than moderate. It's much more like it.
Right.
So again, one of the things I'd like you to do subsequent to our meeting is to kind of write down these two competing pieces and make sense of it. The late Albert Ellis, I think I'm allowed to quote Ellis, he defined neurosis as stupid behavior on the part of a non-stupid person.
Right.
You're not a stupid person.
No.
So how do you continue to act in this self-defeating way?
I don't know.
Justify your mother's diagnosis?
No. No, I'm definitely not trying to justify
useful, valuable, and adaptive about this work?
Very little, if any at all.
People don't do things that don't reinforce them, right?
Right.
So this has got to have some reinforcing quality. So, again, we have limited time, but one of the things where I work with you on a long-term basis, I want to do is get you to look at how you make sense of nonsense. You know this isn't going to help you,
Right.
not going to make you feel better, to make you feel worse. Self-downing never helps. Yet you continue to do it. You know, 80% of your cohort has the same thoughts you do. Like get a good internship, or, you know, I'd be a good psychologist. Right?
Right.
Would you be willing, in addition to that, to do something very daring?
Sure.
You say sure before you even know what it is. Boy, you really are brave. Would you be willing to interview Dr. DiGiuseppe and ask him how he deals with anxiety before a presentation? Maybe you're willing to interview some of our audience. Now, probably when you go up to them afterwards, you say, I'd like to speak to you, they'll cover their face and run away. They're much too anxious. Or interviewing some of your colleagues. We're running fairly close to our time. Is that right, Ray?
15 minutes.
How much?
14 minutes.
14 minutes. How does your anxiety affect you in social settings?
Just in general, like when I'm with friends? It depends. When there's times like when I'm in the middle of a semester and I'm really busy and I have a lot of schoolwork going on. I kind of, like when they ask me to go out and have a drink or go do something in Central Park or whatnot, there's times when I kind of feel like I should do it because it's the right thing to do because I should be social, but then I go out and I just feel like there's other things that I should be doing. I should be reading some kind of a therapy book, I should be doing schoolwork, I should be writing a report. So it makes the experience far less enjoyable.
Global warming?
Yes.
You like big pictures?
Yes. And that's the kind of stuff that gets me the most, that makes me like the most anxious. It's just like the big picture stuff.
If I said to you, every time I take this pen and jab at my ear, it hurts. As a therapist, what would you recommend?
You should probably stop jabbing your pin at your ear.
That a good therapeutic intervention?
Probably put an earmuff on you first.
You all want to find out what early trauma I'm dealing with? By shoving a pen in my ear? Say, gotta stop doing it.
Right.
Do you apply that to yourself? To say, Andrew, stop.
I do. And generally, Andrew doesn't listen.
Because
Because he'd rather be anxious.
you'd rather be anxious.
He would, not me.
Him.
Yeah.
And why would he rather be anxious?
If I knew that, probably wouldn't be here. I don't know. I really don't.
I've had the experience many times of doing relaxation training when people are anxious. I assume you've tried that kind of,
Deep breathing.
yeah. And you see the following thing. I want you to attend to your breathing, in through your nose, out through your mouth, nice and slow. And you can see the anxiety start to diminish. And then what I get is eyes open wide, and they sit up straight, and they stop what they're doing. Shaking your head,
That's happened.
what is going on that makes that happen?
Because sitting in silence makes me listen to my thoughts. The thoughts that I had before I started doing the breathing. So it's like I can either sit here and pretend like I'm doing something, or I can
Distract yourself.
distract myself.
Or maybe answer those thoughts. Do you ever do that?
I
Do you
try
ever
to.
argue with yourself
I do.
and say, Andrew, stop it. This is nuts.
I do.
Does it work?
Not often. Andrew's smart.
So what does Andrew get out of being anxious? Why do those eyes flash open?
I don't know. I think part of me wishes that, like, I guess, but eventually it'll just go away. Like if I sit there and think about it long enough, it's going to go away, whether I can bat it or not.
Does that work?
No, not
So
really.
you keep doing the same stuff?
I mean, it's the same thought. It's the same thoughts that go through.
Right. One of the things I've seen, when I ask people why your eyes should open, they'll say something like, what keeps me safe is looking around and making sure there's no danger. That sounds familiar.
Not like physical danger, but
No,
just
not physical
like,
danger,
but just like, yeah. I mean, down the line.
I don't read the right books, I don't read the right number of books. The danger is I'll be a lousy psychologist, a lousy therapist.
Right. Right.
So there's some danger out there,
Right.
and despite the fact that you've been successful. You still are waiting for the danger to hit.
Right.
So the fact that it hasn't hit yet doesn't matter.
Calm before the storm.
It's going to be there
Right.
any minute. I get anxious just listening to you.
That's reassuring.
Because it's so powerful that it clearly overwhelms you. So in the couple of minutes we have left, what do you think you can do, and what you can do to change this?
Well, I think your suggestion of like talking to my colleagues, my professors, about the thoughts that they have, and maybe realizing that I'm not the only one who's in this position, that might help me a little bit
Okay.
combat some of those like fears that I'm the only one in this position, nobody else is feeling the way that I am, and they have their plans set, and they feel competent as budding psychologists.
I suspect, that's just fun. Are there any graduate students here? Now, take note of who they are. Ask them, are they anxious about the same things you are? What do you think they're going to say?
Yes.
Yeah. Are you afraid, Andrew, of not being the class weirdo? Just like everybody else?
No, I'm not afraid of
So it might be useful to collect some more information.
that. Right.
We're getting close on our time now. Tell me what you're going to take home with you from our brief interaction.
Well, like I just said, I'm not the only one, I guess.
And do you think that'll help?
I think it will. I guess even just like saying these thoughts out loud to you kind of makes me realize how almost absurd they are, just because of how really broad they are. So I'm able to deal with specific anxieties, about homework or assignments, reports, stuff like that. But it's when it comes to like these big, sweeping generalizations that I throw on myself that I like start to have the big anxiety. So I guess if now that I'm saying it out loud, if I start to kind of break it down into smaller anxieties, I could probably combat it a little bit easier than just.
Okay. What else are you doing?
I guess that, I'm not sure. I mean, that was the big take home for me.
But that's a lot.
Yeah, that is.
So you worry about the big things that you have no control over, like global warming, a drought in California, and the little things you can handle pretty well yourself.
Right.
Did I say anything in our brief time together that was insulting or you felt was hurtful?
No, not at all. Not at all.
I always like to check because of my anxiety. You have some homework. What homework are you going to try to do?
I'm going to listen to the thoughts, try to combat them a little bit.
Write them down.
Write them down.
Because as you said, when you see them or hear them,
Right.
they have less power.
Right.
Okay, good.
And then also speak out loud to my classmates. I think that's the biggest homework that's going to help me realize that I'm not alone. And also to my professors too, because I'm sure that they'll be reassuring that they were in the same situation when they were 25.
Name that in past tense.
Right.
I appreciate you doing this. Thank you.
Thank you.
You want to stay here for Kristene?
Yeah.
So you want to open the door back there and yell out to Kristene, say it's your turn?
And then I was great.
Trying to provoke her anxiety.
Absolutely.
There's 2 chairs up here. Chairs to the front.
Welcome to my office.
Right there.
Andrew, thank you first of all for volunteering for that. I appreciate it. So what problem would you like to work on today?
I'm having a lot of self-doubts about being a competent psychologist. A lot of these doubts come when I'm like reading some of these textbooks or workbooks or whatnot on, what makes a good therapist. I recently read like how to fail as a therapist. Felt like,
Did you feel good?
yeah, I did. Yeah, I was like, well, at least I'm not doing most of the 50.
Can I ask you to give me maybe this example? Like when the last time you had this doubt about being confident?
Sure. So the book that I've most recently read was Judith Beck's Cognitive Behavior Therapy's book. And when I was reading that book and just like going through the examples, I decided, well, there's some things in here that I can use on one of my patients. So I decided to use it, or try to use it. And I mean, I fell flat on the floor. And it went really poorly, and I had to basically abandon ship and just like go back to doing what I was doing before.
Okay, so when that happened, when you failed, how did you feel?
A little bit incompetent.
So maybe that's more a thought. When you thought you were confident, did you have a feeling related to that thought?
Yeah, it's a little bit sad that when I've done something in the past, whether it's non-therapy related or whatever, I like to succeed. I'm not a perfectionist, but I want to put forth my best foot and do the best that I can. And when I fail, I kind of take failures a little bit tough because I want to try to make myself better. So I'm kind of tough on myself.
Okay. So what would you say your goal is? How can I be of help today?
To teach me your ways as a psychologist. To, I guess, to help get rid of some of this anxiety and like the thoughts of being a failure and incompetent just because one thing doesn't work out.
Okay, so you said helping with anxiety. So let's say for right now, you read some books, you try it out, doesn't go as well as you'd like, whatever the case may be. That's not going to change for right now. We'll get you to a better place. Let's say that stays the same. How would you like to feel instead of anxiety?
Happy. I mean, like,
Happy if you fail?
not happy but fail, but I guess not upset, not like dejected,
Okay.
not feel humiliated.
Okay.
Whatever the opposite of that.
Okay, so if you're feeling anxiety, do you think, I mean, it makes sense if you want to be successful as a therapist.
Right.
We don't want you to be happy if you don't do a good job at it, right? But we also don't want you to feel anxiety because that's probably getting in the way of you doing a good job.
Right.
Okay. Would it be helpful if we got you to a place where you were concerned about your work as a therapist rather than anxious?
Sure, that's a nice middle ground.
Okay, and if you felt concerned, what do you think would be different?
If I felt concerned, I would probably just say, all right, that was, one instance. Go get them next time. This isn't the end of the road, I guess, but.
So it wouldn't paralyze you,
Right.
and it might help you to become motivated to improve.
And it might help during the session too.
Yes, okay. So would you say that's our goal for today?
Sure.
Okay. So when you were feeling anxious after this session bombed, what was going through your mind? What were you telling yourself?
Worry about, well, I was telling myself that, like, you need to get better at this because you're going to be out on your own soon in the next couple of years, and you need to make sure that you're not doing this when people are actually paying you money to be a therapist, because then you're going to lose your clients and you have any more referrals, stuff like that.
Okay. So I'm going to ask you a tough question. What if you weren't a good therapist, whatever that means for you, but what if you never reached your potential as you see? What would that mean for you?
I guess it would mean that I failed at choosing the right career, failed at.
Okay. So let's say you did. Then what?
I've got to get a new career.
Okay. True. And would it say anything about you if you invested all this time and it didn't work out?
Yeah. I mean, I feel like it would say that I, wasn't. I guess I wasn't who I thought I could be, or wasn't who I thought I was.
And so then what would it say? Who are you then? Or what are you?
I'm a failure.
Okay. So when you say I'm a failure, how do you feel?
Down,
Okay.
dejected,
Dejected. And probably anxious.
and anxious.
That
Yes.
might come true.
Right.
Okay. So if you fail at being a therapist, you're a failure.
Yes.
Okay. As a person?
Not necessarily. I guess as a professional,
Okay. Failure as a professional what? Professional therapist?
professional psychologist.
Okay. All right. So how does failing at this particular profession make you a failure as a professional?
But when you put it like that, I guess that doesn't make very much sense. It makes me a failure as a psychologist, not necessarily as a professional. It would make me a failure as a professional engineer.
Okay. Okay. But a failure is this global rating that you're putting yourself. Rather than I might fail at therapy or a psychologist, you're saying I'm a failure. So even if you failed at psychotherapy, does that make you a failure as a psychologist? Does it eliminate everything else?
Could you repeat that?
Sure. So even if you failed as a psychotherapist, that wouldn't work out.
Right.
Psychologist, total failure as a psychologist.
No, not a total failure.
Okay. So, again, going worst case scenario, this doesn't work out. Are you thinking something like this would be, the worst thing for you? Doing any awfulizing?
Yeah. I mean, it would. I don't know. I think the biggest thing is like I am investing a lot of time, investing a lot of energy,
Mhm.
and have a really strong desire. And generally speaking, whenever I do that or have done that in the past, I have succeeded.
Mhm.
And this is such a long-term process
Sure.
that it's more pressure than what I've had in the past. And so, like in the past, I've been able to get through it, but now it's like a little bit more overwhelming, and I can sense it a little bit more.
So you said a very interesting word. You said, I have this desire. Do you think perhaps, though, if you can kind of go back to that session after reading the book and it didn't go well, do you think perhaps it was even more stronger than a desire? Given how you felt afterwards?
Yeah,
What do you think it might have been? Can you think back to that moment?
a demand, a self-demand.
Which was what? I what?
I have to do well, or else I am a failure.
Okay, so I have to do well or else I'm a failure as
As a therapist,
Okay.
right?
So, do you think it might make sense if we take a look at this thought?
Sure.
You see why?
Yes.
Right, because when you think that, you feel what?
Anxious.
Okay, and your goal is to feel
Less anxious. To feel content. Feel your concern.
concerned. Okay, so earlier I asked you, what would you have to be thinking differently? You felt concerned, what?
If I'm only concerned, then it was just one failure, like one instance in one session, wasn't like my entire career.
Okay, and because REBT is what I call the dark cloud of psychotherapy, CBTs, we like to bring you to the worst case scenario. Okay? Because you're thinking that anyway.
Yes.
Okay, so might as well help you with that.
Right.
Rather than avoid it. So if you never accomplish this goal, do you think that you could accept yourself, even though you didn't? Not like that you didn't accomplish the goal, but accept yourself and not beat yourself up for it?
I think eventually, yes.
Yeah.
Yes.
How would you be able, what would have to happen for you to do that?
I guess realization that this doesn't define me as a person. This isn't like the end of the road. This isn't like all there is to it. There's a lot more than just this singular session.
And how does it help you in the session or in your studies to demand this of yourself and put all this pressure? I must perform well, or I must succeed at this, and if I don't, I'm a failure. Is that helping you at all to achieve your goal?
No, it's not. I mean, at times I want to convince myself that this will help me, that like being a little bit anxious or whatever
Right.
is useful, but in the long run, it's never really been, or if it has, there's got to be better ways than me.
Okay. How is it hurting you? How is it getting in the way of your goal by thinking I have to do well or else I'm a failure?
Well, I'm spending a lot of time on that thought,
Okay.
so I could be more productive in doing other things to help myself not fail as a therapist. But I don't know, it's just like this circular thought in my mind. It's just like, get to one stage and then just like right back to, well, you'll be a failure. Round and round it goes.
So how do you define failure?
Not helping my patients, or making my patients worse would be like the ultimate failure. That
Okay.
would be like the worst case scenario is like my patient turns out, leaves me and either, it is just like ends up being worse than they were before they were with me.
And do they have any part of the therapy process, or is it all your responsibility?
Some of it is on Tim, a lot of it's on them, I guess.
But it sounds like,
I put it a lot on myself.
yeah, okay. So a failure is someone whose patients get worse.
Yes.
Okay. So if I told you that I have some clients that actually do better when they're not in therapy with me, which is true, I'm being honest, that is true, where it's like, they go on vacation, they're better, I go travel, they get better, so that means they get worse when they're with me. So that means I'm a failure. Thanks. Thank you. Great.
definition.
Okay, so I would say that pretty much you have defined the entire world of psychotherapy, the therapist, as failures.
That's nice of me, I guess. Well, now I'm not just anxious, now I'm an asshole.
Why we have job security. We make you worse before we get you better.
Right.
All right, so but if you see that this belief is not helping you, and also it doesn't make much sense, right?
Right.
Because aren't you much more complicated than one behavior, one act, one profession?
Yes.
Yeah.
It's a lot more than that. I mean, saying it out loud, now, I'm like realizing how ridiculous some of those statements are.
Okay.
When it's like broken down a little bit, it makes it sound better. Like I'm not quite as much of a failure as I thought.
It sounds like you're more human than a failure.
Yes,
Are you allowed to make mistakes?
I am allowed to make mistakes.
Can you accept yourself even though you make mistakes?
It's tough.
Mhm.
There's a lot of like beating myself up before I can accept it.
And beating yourself up sounds like what? What do you say?
You know, I'll like replay the session in my mind and think like, or actually like replay the session in front of me on video because we record the sessions and think like, why did I say that? That was so dumb. Like you should have said this. There was so many other things that you could have said. There was a different way to handle the situation more confidently, and it's just like I always find a better way to do it than how I did it in the moment.
Which is not necessarily a bad thing if you are looking and reviewing your work and seeing what you could have done differently. That part I think is good. I think that's going to help you become a better therapist. But I think that beating yourself up is going to get in the way of that good thing that you're doing.
Right.
I should have done this differently. Why? Why should you have done something in therapy differently? It sounds like a crazy question, but think about it. Let me know.
I guess I should have done it differently because in that moment, I guess it would have made me a better therapist. And I guess if I had done it differently then that made me a good therapist in the moment. That makes me a good therapist down the line because I already know how to do it rather than have to like learn or teach myself how to do it. I feel like these should be like almost innate things to me at this point.
Like, book you're a good therapist.
Right.
Okay. So you answered a question, but you didn't answer my question.
Okay. What was?
Okay, no, that's okay. I said, why should you?
Why should I?
And you said because then that I'll be a good
Right,
therapist.
right.
That's a reason why it would probably be much better and highly preferable
Right.
that you do whatever the right thing is at the right time in therapy. But is that a reason why you absolutely have to?
No. I guess there's no reason why I should.
Okay.
There's just reasons why I would like to.
And if one of your classmates came to you and said, I completely screwed up that session. I tried to do this strategy and it backfired, and I'm such a loser. I'm such a failure. Would you agree? Uh-oh, pause me, yes.
No, I would
No?
not agree with that.
Why?
I would tell them the opposite.
Really? Why? Same thing. They screwed up.
Well, I don't know, because now that you like say it like that, it's like, well, why would I do that to myself if I wouldn't do it to them? But I don't know. I guess one failure in the moment doesn't make you a failure as a person, or as a professional, or as a therapist, or even that entire session as a failure just because of one moment.
Right. Okay. And when you say that out loud, how do you feel?
Better,
What is better?
less, I guess, less downtrodden, less beaten on myself, less anxious about the future.
And then if you feel this way, what would you do? What could you do?
I guess I would be a little bit more optimistic in my future sessions, and maybe be able to handle some of those like in-session failures a little bit more competently, or just like take them in stride.
Right.
You know, just learn to learn from them.
Yeah. And it's interesting because I imagine, going into a session, making yourself feel anxious, like, oh my God, I have to do a good job here. If I don't, I'm a failure. All that pressure. Do you think you're really present with your client?
No. And sometimes I have to snap myself out of that
Right.
because it start subtracting, and then I lose thought of where they're.
That's right, because you're kind of like spectator, you're on your shoulder, analyzing everything you're doing, and, right?
Rather than
So actually, if your goal is to be a good therapist, by demanding all this and putting all this pressure and beating yourself up if you're not, and catastrophizing about it, you're actually getting away with your goal.
Yeah.
And if any of what you were saying made sense, I'd say keep it, right?
Right.
But
It doesn't.
it doesn't. So let's say next week you go into your session. What are you going to be thinking as you're working with your client?
Do you mean like what will I try to be thinking?
Yeah.
Okay. I guess I'll try to think that like just because I make one mistake doesn't mean that the session is going poorly. I need to stay focused on what's happening with my patient rather than what's happening internally, and then maybe after I can replay it and help myself out then, but also realize that like if something went wrong, that's just one instance. That doesn't mean that the session was catastrophe.
Okay. And even if it is a catastrophe, again, whatever that means, then what?
Even if it was a catastrophe, then it does not necessarily make me an awful therapist.
Because
Because one failure doesn't define me as a person, I guess.
one failing,
One failing.
right? Because there's a difference between failing at something
Okay.
and then being a failure, right? And I think what you're doing is you're saying, let's assume you did fail at this session.
Right.
Then you're making that define you as a total
Right.
professional. Does that make sense?
No, it doesn't. Because just one instance. It's
Right.
not.
Even if it's 10 instances,
Right. It's not a career.
it's not you.
It's a building.
Right.
It's a learning process.
Because, I mean, I don't suspect this, but the truth of the matter is you just might not be a good therapist. Right?
Right.
And again, it's very subjective, and you can have outcome measures and all of that stuff, but that could happen.
Right.
And if that were to happen, worst case scenario, would that be sort of the end of all your happiness, all your satisfaction?
No, because even hearing that out loud coming from you, like you are a good therapist. I mean, telling me that, but like even hearing that out loud, like it makes me feel really bad, but it doesn't make me want to jump off a cliff, or it doesn't make me think that this is like the end of my life or anything like that.
Okay.
Like I'm gonna combust as a human.
Okay, good. So you said it makes me feel like, so you're making yourself feel differently. What you said when I said, even if you're a bad therapist. So what are you thinking about hearing that is having a shift in how you're feeling about it?
I'm thinking that this is a more productive way of looking at it.
Okay?
And that's the biggest thing right now.
Because your goal is?
To only, what is the C word now, I can't remember.
Concern.
Concerned, to only be concerned and not to catastrophize.
And I pay very close attention to words, right? So you say to only be concerned. Concern is a good thing, right? It's not only like, I'll just be concerned. Concern is not, it's a healthy negative emotion. Because you do have a goal, and we don't want you to feel nothing. You'd be dead, you would have a pulse.
Right.
We don't want you to be happy, but concern is less likely to get in the way of achieving your goal, right?
Right.
So, I'm your client,
Okay.
okay? And I totally screwed up something at work. And I'm super anxious because this really could be the end for me. And I'm a total failure. Help me.
What does being a failure mean to you?
Just inadequate. I'm not good enough.
I'm not sure where to go from there.
Okay, I did that. You know why I did that? Because I wanted to test out whether or not you were sort of buying into what we're talking about. So would you agree that I'm not good enough if I fail?
No, I don't agree that you're not good enough. Because it was just, it's just a job. It's not everything that makes up who you are.
But this is so important to me. This is like the thing. I spent all this time money invested in this, and I just not good enough.
I guess it just doesn't, I'm not sure how to word it correctly.
It's okay, just say it.
I mean, that doesn't make you, well, I mean, you know, it does not make you a failure. It makes you human. It makes you, there are other people out there who have been in the same situation, who, yeah, I'm not sure where to go.
Okay, so, but you said that I'm human,
Yeah,
and being human means making mistakes
mistakes.
and being flawed.
Right.
Okay, so let's go back to your next therapy session. Let's assume for now, because it's just, you know, we just had one session, that you start to feel anxious going into it. So let's go back to what you can think differently to help you feel concerned about what's happening. I want you to do that, right? But not anxious, where you're more likely to not be present and make mistakes. So
Right.
what would you have to do to start feeling anxious?
Tell myself that that I need to remind myself to stay present with my patient. I think that's like the biggest thing that I need to do, because that's just not going to help anything. And I'm definitely not helping my patient if I'm.
Which is good. How are you going to stay present?
Tell myself that this one instance doesn't make myself, you know, I'm going to learn from this, I'm going to become better from it. I'm not going to label it as an instance of a failure.
Or you as a better?
Me as a failure, or this is a failing. But it's going to be okay in the long run, and I will get through it, and I will learn from my mistakes.
And that's good. That's very good. And keep in mind that by, you know, if you start to catastrophize about this, oh my God, you know, this isn't going well. What if this doesn't go well? You know, how is that helping you? Right? It's not helping you at all. Okay. So even if something happens in a session and the session bombs, it's not the end of the world? Question mark?
It's not.
You sure? Because I don't, that's my, you know, that's my evaluation.
No, it is not the end of the world.
Okay. It's bad, right? Yep,
Yes.
it is bad.
Yes, it is bad.
It's bad.
It is bad.
But it's not horrible.
Right. I mean, it's bad, but
It
it's
is
not.
bad. It is bad. I mean, it's not good, right?
Right.
It's definitely not good.
Neither my client nor myself walks out of there feeling good, so it's like,
Right.
it sucks, but it's not end of the world.
And when you say that, how do you feel?
A little bit less anxious than I was before.
Okay.
And I actually believe it a little bit more saying it out loud
Good.
than just like thinking it in my head.
Right. And that's really where you're going to go from up here, like knowing it sort of intellectually, I get it, it's not the end of the world, but to believing it in your gut is by rehearsal, practice, right? Because that sounds like, my guess is a graduate student, you know, we make ourselves neurotic and crazy and perfectionistic, right? So you sort of
Right.
built up this muscle, this emotional muscle of, I have to be good, if I'm not, I'm a failure. So you walked in with a very strong left muscle.
Right.
Right? So what we now need to do is get the right arm and build that muscle. And you can't go to the gym and look at the dumbbells and say, oh, that would be a good idea to pick up, and, you know, and walk out that slowly. You got to pick it up, and you can't just do one, right?
Right.
It's repetition.
Okay.
Okay. So maybe we could talk about a little bit about homework.
Sure.
So based on what we talked about today, what do you think would be most helpful for you to do to help you strengthen the conviction of this new way of looking at it that will help you feel concerned?
Well, I think writing it down and maybe like reading it before and maybe even after sessions
Okay.
could be useful.
Mhm.
And just repeating it to myself over and over again until it kind of just sticks there and it's like actually
Okay.
a happy thought.
Happy thought or more accepting,
Yes.
right?
Right.
More reality based.
Right.
Okay. So one thing I would say though is you may not want to wait till right before the session to read it.
Okay.
Because that, in the beginning, of trying to change a thought or a behavior, it might be too late at that point. Things that might, be there. So maybe when you're not, when you're feeling more calm, reading it, over and over again, and still when you go into session and after, but don't wait till then. to do
Okay.
it. Does that sound reasonable?
Sounds
And what would you write down?
it is okay if I make a mistake. It is not the end of the world. It doesn't define me as a professional.
Okay, good. So do you see anything that might get in the way of you doing this assignment?
No, I don't think so.
No?
No.
Okay. And if you know that it's there, but you're not really looking at it, what are you going to have to tell yourself to get yourself to do the assignment?
This is going to help me in the long run, and it'll actually end up making me a better therapist if I can teach myself to think in that way rather than thinking in the way, because what I'm doing now is not working, obviously.
Right.
I mean, I don't feel like I'm a failure yet, but I just feel like...
It's always that possibility, right?
So it's just like preventing myself from continuing to think it.
Right. And you just remind yourself that you are being somewhat of a hypocrite when you do not judge other people if they fail.
Right.
And so you're so special you get to be worthless and a failure, right?
Right.
Right?
Yeah, that's
so,
true.
If you're a scientist, you gotta, don't skew the data. You gotta look at all the data.
So I can either tell them that they're failures
Exactly.
or...
Feel better about yourself. Externalize. I didn't have externalize. Don't internalize.
Right.
Right. Okay?
Okay.
Okay. So thank you very much.
Thank you.
Okay, thanks.
Done. So let's hear from Andrew. What was your experience as being a client in these cognitive behavior therapies?
No surprise.
It was useful, I guess, like actually getting these thoughts out loud like definitely helped me feel a little bit better. The approaches were, in terms of the approaches, there was a lot of similarities between the two, and like getting me to work on these thoughts and getting me to, I guess, realize that a lot of the stuff that I was saying just didn't make any sense. And I guess like saying it out loud and then helping me like get a different way of looking at it, both of them helped me do that.
So somehow saying the thoughts out loud that were running through your head really sort of allowed you to look at them a little bit more objectively.
Yes. And then also having like somebody else, just like an objective observer, who could kind of point out these flaws in logic and like show me that like Kristene said, like I'd be a hypocrite if I did it to myself and not to others. That kind of thinking is just like that was really useful.
Okay. Anything else?
No, I mean, but it was fun. It was actually kind of fun to like be on the other side and to kind of like put myself in a patient's shoes again and to like see like what happens. And both are so very, very good at what they do, and it kind of like from the beginning I could already kind of see where they were leading me. It helped me like kind of realize like, oh, this is going to make me better if I kind of.
So let me ask you this question. How did you feel you related to them as people, and how did you think that they related to you? Some people often criticize cognitive therapy and REBT, all cognitive behaviors, as not really paying enough attention to the relationship. How did you feel they related to you as a person, and how did you feel towards them in terms of an interpersonal relationship?
So I think with Art, it was a little bit more like he was kind of like leading me in a certain direction and kind of pushing me toward like a certain answer, but very like smoothly. And it felt like very empathetic too. We've all been there. We've all experienced this. This is normal, kind of normalizing it.
So his normalization you felt as empathy.
Yes. Yes. With Kristene, it was a little bit more direct and kind of like pushing me toward realizing that that's stupid.
I'm thinking that.
And I think like
She says it more directly to me.
sometimes you need that, and I realize that's not for everybody, but for me, like sometimes I need somebody to just kick me in the butt and say like, stop. Just, that's not logical, that's not right. And so it was like, from that standpoint, it was like two completely different approaches, which is like, I don't know, for me it was cool to be on both sides.
And did you feel close to them?
I did, both of them. Both of them, there was a good like therapeutic relationship there. I definitely didn't feel like either one treated me poorly. I apologize for using a cuss word earlier. But a few.
Hello, Albert Ellis.
But
Which word was that?
the a-hole word. It was that moan. Ooh.
Okay. Any other experiences that you had?
Definitely a sense of relief at the end of both of them. Like toward the end of both of them, it was like, okay, like this is manageable. This is something that I can actually do, and like the homework, the tasks that they've given me are like not overwhelming by any means, and they're definitely something I feel like I can do.
And did you feel that the homework was something that they assigned to you, or that you agreed to, or that you know?
It was kind of mutually agreed upon, but I kind of set it for myself, and felt like it was something that I can actually do, and not like they're telling me that this is going to help me, but me telling myself that this is going to help me.
Okay. All right, so let's throw it open to the audience. Any
Can I
questions?
just say
Oh yeah, listen.
I thought what you did was great, and I thought, shit, I should have done that. When you did the role play within the role play,
Yeah.
it was a great, great thing to do. And I'm really sorry I didn't do it.
We accept you.
I feel like just a partial thing.
Okay. Yes.
I was just wondering, what was it like for you to have her go to the worst case scenario? Because that's a little different for me to witness.
And so the questions over here. The question is, how did Andrew feel when Kristene said, "Let's go to the worst case scenario"?
The dark cloud of REBT, I think she referred to it as, right? Yeah.
My gut dropped. It really did, because it's like you hear it out loud and you're like, that sounds like really, really bad. And then it settles for a second and you're like, I'm still here. So it was useful in that sense. Like it helped me realize like, man, even if I'm at my darkest place and somebody else says it to me, like, and I'm not just saying it to myself, even if somebody else says it to me and calls me a failure, I'm still okay.
But it was very emotionally arousing.
It was.
Right.
It was.
Really
Yeah.
got your feelings aroused.
Right.
Okay. All right. Yes, Steve.
You have this realization, she's telling me I'm doing something stupid.
Mm-hmm.
So lots of opponents of cognitive behavior therapy, they really point out that we may be providing, I consider myself a cognitive behavior therapist, we may be providing clients with a failure experience. Oh, one more thing, I do badly. Did you have any sense of that?
Yeah, for a second. It was like one of the like split seconds, like, man, like there's something else to add to the bucket list. There's something else that I'm like, gotta like figure out how to fix now. But then you kind of realize it's like a little part of the issue that you're already thinking about, that you're already dealing with. And so that kind of like, I guess, I realize that not all clients will think the same way as me, but like, it actually helped me a little bit realize that like, eventually that thought's gonna come. The thought that like they would give me, so it's better that it comes out here and now so that we can work with it rather than like me have it later and not realize this is just one little part.
You said something that many of my clients who happen to be college students say. They will say, that would suck.
Mm-hmm.
So is that pretty bad?
Yes. Yes.
I'm wondering if you could add, that would suck, but I would not suck.
Yeah, that's actually a good way of looking at it. That would suck, but that doesn't necessarily make me suck.
Yes.
I liked the way both of you used humor when you were pointing out the faulty thinking. Global warming on top of everything else, I like that. I like to use that. And it was interesting to have you back to back. I almost thought that you got him started identifying and perceiving some of his thoughts, and then you had him there ready to think about them, perhaps, because. And I don't know if you noticed this or if anybody else did, but your affect, when you were talking to Art, was a little more flexible. I saw more emotion, both kind of the fear and the kind of letting go and the breathing. And with Kristene, there was like this concentration, you know, she would say something and you were answering. And so I just wondered if that experience was partly because of the time in a broader session from your perspective, or did you even notice that?
I actually didn't notice it. I tried my best to
On the
treat them
spot,
as
yeah.
like two like completely separate therapies. I tried my best at least, but I'm sure that like part of me was like, at the beginning it might have just been more nerves on my part, and then kind of like settling in. I know that like halfway through art session I like felt a lot less nervous.
Art?
It raises a whole, it's a great insight. The whole idea, because everyone likes to name a therapy after themselves. You know, life is not complete unless your own therapy.
I did it just the other day in class.
Right.
You know, have tag team therapy. You know, start with one therapist, switch to another, maybe even a third, because each of us brings something different. But I think the perception, humor is something very important to us. That I think our major trainers, Beck and Ellis, use humor all the time. And they taught us, you know, it's like testing the mirth response. If you say something like global warming, and the patient looks at you and goes, yeah. You go, uh-oh, I got big trouble. But if they can respond to it, it says there's something you can tune into. That's useful.
So I just want to respond to that. I think it's very hard when you do these comparative psychotherapy sessions to take out the confound of who went first, and the client really isn't as naive and they may have a little benefit. So Kristene may have had the benefit of Andrew having improved a little bit as a result of art, at least we would hope that, right? And so it's very hard to have a non-confound and still see the same, different therapies with the same client. So it's hard to take that out. And to add one more thing to what Art said about humor, actually we have a professor who's at St. John's, who's a clinical psychologist and studied with us, and who does research on humor and is a stand-up comedian. And you know, it's very hard to teach people humor. And we're not, I don't think the psychotherapy literature is focused on that. There's not a good literature on how to teach people how to be funny. And basically we do it by modeling.
There's a movement within psychotherapy to use improvisational techniques for physicians, for psychologists, because every session is an improv. I mean, they say, we say, they say.
So we should work with Second City.
I met, I did a presentation on Tuesday, and a woman gave me her card. She's a Second City graduate who's now teaching medical students in Chicago how to be improv with a patient. So I you know, that may be the closest we can get to humor. But I agree, you know, tell me a joke.
So I agree with Art and Kristene. I think that humor is really an important part of therapy. I think humor, you know, humor really comes from taking a word that has two meanings and you change the context. And when you change the context, something is funny. But when you change the context, you're kind of reframing, and you get people to see that there's two different sides of something. And that's really what cognitive behavior therapy is about. So I think humor is a great technique. I just don't know how to teach it, except through modeling and sending people. Actually, Wilson McDermott is the guy who's the psychologist and the stand-up comedian. And maybe we gotta have Wilson do a workshop on humor and psychotherapy.
You know, my comment about global warming wasn't just to be a smartass. The idea with many patients, and I think Andrew is one of them, is he takes things to extremes. So my view is, if someone's at an extreme, you take a position even more extreme, and you kind of move them toward a more moderate position. So if I say, including global warming, he says, no, not global warming, he's already moved toward a more moderate belief. That global warming that's stupid. Aha. So it's not meant just to be humorous. People will often say, no, I've heard Ray respond to this too. Someone will say to us, "Did you mean to do that?" There's very little in therapy that we do that we don't mean to do. It's not simply a conversation. So when I say global warming, I'm trying to take Andrew to an extreme. And if he says, "Yeah, I'm responsible for global warming," how about the drought in California? Yeah. That's a quote.
Michael, your question?
Sorry, I'm just going to move the camera away so I don't shout in the camera here. So this is actually a question from, Andrew, your perspective as a client, and then for each of the therapists. One thing that I noticed, in the approach, I think both of you ended up getting him to a point where he was seeing what he was thinking and identifying that and changing that is going to help him. But in the beginning, I noticed, Andrew, that Art kind of talked about things that weren't directly related to your problem. He was talking about public speaking, kind of playing on some of your strengths in terms of, getting data and how you're doing really well here, and most people are anxious in this kind of situation, how are you getting through that? Whereas Kristene kind of went right to the presenting problem that you were talking about. And so I guess as a therapist, primarily REBT, I kind of go toward where Kristene is going with that direct, So I was wondering for you, because I could see pros and cons of both those approaches, how'd you experience that? And then from the therapist, what is it that, why did you choose to do that?
Well, it's interesting because the way Kristene did it, getting right into it, that's what I'm used to seeing, or videotapes that I've watched or things that I've read, or just my approach in general, that's kind of how I'm used to it. And the way that Art did it, like you said, it was play on some strengths and say well, you do these things so well and they don't make you anxious, but they make so many other people anxious. That was really interesting because that kind of already started getting my brain turning and thinking, wow, that actually, I do have all these other good things going for me. And that's things that you don't think of when you're thinking of all these bad things. So it's that kind of helped give me a different way of looking at it. So both approaches were actually really useful.
I would like to comment on Art's procedure. When I teach cognitive behavior therapy, I can't help it, but for Art in my generation, we've always said that the best cognitive behavior therapy was the Peter Falk detective character in the TV show Columbo, which you can only get on Netflix now. And I kind of thought you were a perfect Columbo. And so you took him in this area of, you do this right, you do this.
What do you mean?
and then you sort of put these two things together and created this cognitive dissonance, which I thought was really, really brilliant. And I think that I always recommend to my graduate students that they go to Netflix and watch the Peter Falk episodes of Columbo to learn how to do this circuitous questioning and then point out some inconsistencies in the way clients think.
Can I just respond to what Michael was asking? So the way that I approach therapy is I start with the concrete problem, what obvious, and then we do this general semantics, act, letter, or abstraction. So we'll, start concrete, go a little bit more abstract, go back down. Because my experience has been with some clients that if they come in with concrete and I go too abstract, you don't understand me, that's not my problem, that's not what I'm saying, I don't care about the entire world, I'm talking about my partner. So I try to stay very concrete and then sort of test the limits of how far in order for the client to accept what we're talking about.
Yeah, the whole idea of conceptualization, I think, is key. And one of the criticisms of Albert Ellis was, he meets a patient in Freeman, he starts doing therapy. No. Al was so good and so sensitive and so clever that he can develop conceptualization in the blink of an eye. And I had asked him about this. You work from a conceptualization. He said, of course. So when you sent me this material,
Start thinking about it.
I started thinking about it. And I thought to myself, wait a minute. Here's a guy who's anxious, but now, if I say, why are you doing this? He says, well, because Dr. DiGiuseppe told me if I did it, I'd get extra credit. Or if I don't do it, he'll throw me out of the program. Fine. So that would raise the idea of schema about assenting to authority. So, I started conceptualizing Andrew long before I met him. We start developing our conceptualization with the first phone call. I'd like to see you for therapy. What's the problem? So, you know, this is really the result of a lot of thinking. We, you know, to answer me being very, you know, concerned about this, you know, we don't just jump in and start slapping techniques on them. We do a lot of thinking about it to develop our model and how this fits.
So I think what you're saying is that, and I think a lot of people don't really understand, is you're sort of developing a set of hypotheses about what the conceptualization of the client is from any information that you get very early. And that, you know, I always like to quote Thomas Kuhn, this is a science or philosophers of science say you can't help but have a hypothesis, right? You can't help. And I think we would encourage people to allow themselves to have their hypothesis. So any other questions that I can? Yes, Giovanni.
I have a question to Arthur Freeman. What's your opinion about the worst scenario technique? Do you accept this representation in which worst scenario is more important in REBT than in
No.
Don't you?
I think to say, what's the worst thing that can happen? And I said, I don't know, is the world going to stop turning on its axis? Well, no, that's stupid. So what's the worst thing? And again, when you have someone like Kristene do it, with such skill and such polish, I think people often don't understand the weight of that intervention. I think it's a great intervention because it takes it to an extreme. As I said before, what's the worst thing that will happen? You know, are they going to throw you out of the program? Now, I mean, do you think at some point some patient may say, you know, I'm not coming back to therapy?
Yeah.
Think that'll happen?
Yes.
Dr. DiGiuseppe, has that ever happened to you?
Absolutely.
It happens. So we can't say, boy, I screwed that up. Now, sometimes you do. And we say, okay, I've learned from that. So it's been useful. But I think that's a great technique, taking things to an extreme.
Yes, but do you agree that you use the worst scenario in order to show that this worst scenario is a stupid thing?
Would I
So
do that?
probable? Because in REBT maybe, yes, the worst scenario might happen. It may be stupid, but it might happen. Good things happen.
I would use that technique. I was trying to be real careful because Ray warned me earlier. Because I studied with Beck and I also studied with Ellis. So he said, be Beckian today. So I was trying to be more Beckian and not you know, get mixed up in that
I'm an amalgam.
the REBT stuff.
So,
Yeah.
sorry. Another question.
When you use the worst case scenario, he kind of habituated to it quickly and was able to process it quickly and move on. I was wondering about clients that can't do that so quickly, or that, you know, have much more emotion attached to the worst case scenario, and when you can't move on from that as quickly. What are your thoughts about that? How do you manage that?
When you can't move on from the worst case scenario,
Yeah.
well, that's what you work on, right? Because
Right.
that's what, when they go to sleep at night, turn off the lights, that's when the worst case scenario pops up, right? Which is why we, from my perspective, we go for it pretty quickly because it's more elegant and it's more efficient.
And it may not happen in a session. Right.
Exactly, right. I mean, there's a pace to therapy and everyone's pace is different depending on, you know, where the client's at, who's been coming in.
I think we have to put aside our narcissism to say, well, if it doesn't happen in these 45 minutes, there's a problem. My goal, especially with the homework, is to send the patient out to collect data, process that data, because CBT is an information processing model, and come in the next session and say, how did the homework go? Well, I spoke to classmates, and only 2 of them said they're anxious. So I'm actually in the minority. Good data. It's good data. So I want the patient to be primed to work on their own, because once therapy is finished, everything is homework. And if they don't have a homework model, they're in trouble. They become therapy junkies.
Yeah, Kristene, you get into it so quickly. I really have two questions. Number one, what's the modal number or the average number, however you want to look at it, of sessions that people have with you? And secondly, maybe this should have been first, is it's clear that an arts model, you do conceptualize and get a lot of data beforehand to think about it. You're doing this in a more interactive fashion. You usually don't have all this data on a very articulate and psychologically minded patient. What's happening in terms of your conceptualization as you go on?
Okay, so just, I'll answer the first question. Thank God Art printed this out, because I didn't look at this part, I just looked at the beginning slides that you had. So all I saw was, I met Andrew outside, I knew his name, and I saw anxiety. I don't even know what's on the second page. So for me, based on the RBT model, my conceptualization is that there's, probably demandingness and awfulizing. So my questions and my comments were hypothesis driven. So I'm willing to be wrong, but based on the model, I know pretty much where anxiety comes from. So I don't need to know. Like at the Institute, someone makes an appointment, I don't speak to them until they walk in. Usually, not always, but usually. So I go with what they give me at the time, ask my questions based on what I know about RBT. So that's that first piece. And the second piece was modal number of, they say short-term therapy. I wish my client. Well, it's hard because my clients often do not come in every week. They come in every few weeks. So I have clients that I've seen for years, but they're not coming in weekly. They come, they start weekly, and they come in, once a month, once every 3 months. They hit a bump in the road, they come back. So I don't really have an answer for that. There's so many factors.
I can give an answer to that, because we've taken data on that at the Institute for RBT over the years. And part of Walter Patrick's dissertation, we looked at predicting session length, and so we had some data. Probably the median number of sessions is around 18, and 25 is like the 75th quartile. We get very few people who drop out in the first 5 or 6 sessions. And I think that's really the key data, because if you look at psychotherapy treatment length data, many people do drop out in the beginning of session. And I always said that one of the things that we go back to Jerome Frank's book on Persuasion and Healing, and that the purpose of the beginning therapy sessions is remoralization and hope rather than diagnosis. Because if you spend 3 sessions doing a structured interview for DSM and the client leaves, well, you haven't done any good. If you give them hope, then you can more accurately assess a diagnosis once they trust you and they have some hope. So we have fewer people dropping out in the beginning, but of course, it's not magic. Steve, you had another question.
Question for Andrew. So, do you ever feel anxious when people ask you questions?
That's meta. What do you mean when people?
Well, so a lot of questioning in psychotherapy, and every time I've heard a CT therapist give a presentation, not every time, but mostly, they focus on Socratic questioning as the way to get to all of the problem beliefs. And I'm wondering if that kind of questioning had any anxiety-provoking component in and of itself. You're asked a question, you don't know what's wanted in the question, so you feel
It's not knowing
and
what's
uncertainty.
It's not knowing what's wanted. It's more of so yes, I do get a little anxious. I mean, not normally, but like during these sessions, it was to make sure that I was like fully understanding what they were asking, and then also giving a well thought out answer, so that it was useful for both them and me. Because I wanted to make sure that, and I'm one who likes to make sure I'm being very rational about the way that I'm thinking things through.
So Socratic questioning itself could be a generator of distraction.
It could be, yes.
Tony.
Yeah, just a general question. In terms of engagement, we work with a lot of people with quite serious mental health illness, such as psychosis, and the idea of engaging them initially and making them feel comfortable, I think is a very important point here. because I came in late, Al, I'm sorry I missed that because I was still on, the other side of the world. But here you've got a sophisticated client, right? But mostly you don't have sophisticated clients. And do you want to comment about that part of therapy, to engage the client, to make them feel comfortable, not sort of threatened and overwhelmed by the doctor? Any comment?
Once again, in my working with individuals with chronic mental illness,
Yeah.
some relate very well. They relate well to the chair, to the table, and to people. Some are very frightened of almost everything. So I think the first thing you want to do in any kind of therapy is develop a working relationship. But I would divide the relation into two pieces. There's the working alliance, which is the contract for the therapy, and the therapeutic bond, which is the relationship. But I'd separate those. With certain patients, we do alliance. This is why you're here, this is what we help you. With other patients, especially with kids and with chronic mental patients, the bond is essential. Well, the goal is to reduce your hallucination. That's not going to go real far. So it depends on the patient. But with the kind of patients you're talking about, we start with the bond and emphasize that. And then we go to the alliance.
So I have a question for Andrew. Did you notice their Socratic dialogue? Because there were very few declarative sentences that Mark or Kristene used. And how did that feel? Following up on Steve's question about there was an anxiety program, because they didn't use many declarative sentences.
Right. I didn't really notice it during the session. Now, like looking back on it, I can definitely see that happened. But during the session, I wasn't really thinking about it. But I was noticing, like, man, I feel like my own patients would like to talk a lot. But I guess it's just because I'm also asking them a lot of questions. So, yeah, I mean, it didn't occur to me during the session, but now that I think about it.
Right, most people, they see the term Socratic dialogue, and I'm not sure they know what it is. Socratic dialogue is not simple a random questioning. There's a goal in mind. If you do a Socratic dialogue with a suicidal patient, I know where I want to end up. It's not just random. It's much more focused. So basically, with Andrew, I wanted to see, could I help him reduce his anxiety? Could I impact on his thinking that creates the anxiety? So I have a goal in mind. The question is, how do I get there?
And so did Lieutenant Colombo. All right, someone else had their hand up. Yes, sir.
So, when Art, you asked about the anxiety, like reinforcing quality of anxiety, how long in history were you thinking as a cognitive behavioral therapist?
Well, he said his anxiety was diagnosed by his mother at ages 3 and 4. Now, he may have been, I don't know, maybe he comes from an anxious family. It may be temperamental. He's just very easily aroused. Maybe his mother said to him, don't go out in the rain, honey, you'll catch cold, you'll get sick, you'll get pneumonia. I don't know where it comes from. But again, the issue in CBT is not where it comes from, but what reinforces it, what continues it, what keeps it active today. So that's where I'd want to go.
So a bit more courage than
I have another comment that I'll ask Andrew to comment on. There was a process that I noticed listening to both the therapists that no one else has commented on. Both of them made frequent questions about whether a thought or a behavior worked for you. When you have that thought, what's the outcome? Does that help you? And that there was a lot of questions about the potential consequences of your affective, cognitive, and behavioral reactions. Very operant in the model, So a lot of the reason that they sort of proposed for giving up on a thought was, is this working for you? Which I know sounds a lot like Dr. Phil. But were you aware of that? Was that something that you thought about?
Yes. That I was a little bit more aware of, and it was also extremely useful.
So you weren't aware that these things weren't working for you?
Right. It's like when you're like thinking about all these things, you don't pay attention to like things that like, you think about the thing itself and you don't think about things that might be more useful. So like them pointing out that like a little bit of a, I don't know what you call it, almost irony or like whatever, but that was probably one of the most useful things that both of them did. And it kind of made me realize that's
So really it's a very basic reinforcement principle that was embedded in their Socratic reasoning that they asked about your cognitive and affective behavioral reactions that really ties the cognitive to the operant behavioral stuff. And I think a lot of people forget about the behavioral roots. We're so cognitive that we're not behavioral enough, and this was a really important behavioral reaction. Thank you. Maran?
Hi, I'm sorry I missed this part of the demonstration. My question was for Kristene. When you do go for the worst case scenario, do you ever, and if so, what types of situations do you teach, like some kind of distress tolerance or relaxation techniques rather than going straight to the dispute when the client isn't very emotionally aroused by the worst case scenario?
So, bringing up worst case scenario, they have a very strong emotional reaction. I would really do an ABC right then and there. Like, what are you feeling right now? Whenever there's a strong emotional reaction, whether it's anxiety, anger, whatever it is, it's a great opportunity because I'm going to get to their core beliefs that are creating it. So, rather than distracting them from it, I would want to sort of, utilize the moment to work on it. That being said, there are times, obviously, clinical judgment where you may have to, reduce their level of arousal so that you can even do any cognitive work. So it's more about clinical judgment, but I typically don't shy away from seizing any opportunity in session. I like it when my clients have a reaction. I've hit something.
Yes, sir.
I just want to mention something real quick, and I really appreciate Dr. Doyle because sometimes I encounter that with my clients. Is that the client here? She really wanted to differentiate the thought and the emotion. I believe you asked a question and he replied with a thought, and she was like, "Well, that's the thought. What is the emotion?" And going back just to the basics, sad, happy. And sometimes I run into that with clients. I don't know if anybody else here that they cannot clearly delineate what is a thought and what is an emotion and the consequences of this.
Yes. And they say, I feel that people should respect me. That's a thought, you're couching it as a feeling. Right, yeah.
See, I think in all kinds of CBT, the importance between a thought and an emotion, a thought and a feeling is crucial because you can challenge, debate, examine thoughts. You feel is what you feel. Feel is experience, and they're not open to debate. You're not going to challenge, and so you could get yourself in a position of really invalidating a client if you are challenging a feeling. Because if you feel cold or hot or hungry here, who am I to say? And it's not open for debate. So I think that we would say that's a pretty important skill to do.
This is also a function of English. Who here speaks fluently a language other than English? What language do you speak?
Spanish.
Spanish. You speak Italian, obviously. What else?
Spanish.
Portuguese.
Danish.
Hebrew, okay. Let's pick Hebrew. Say in Hebrew, I feel like a failure. Now, translated word for word back into English.
I feel like a failure.
Okay, in Portuguese, I feel like a failure.
Eu sinto como se eu tivesse fracassado.
Word for word back into English.
I feel like if I have failed.
Okay? In Italian, I feel like a failure. Can you say that?
Mi sento fallito.
Word for word back into English.
I feel a failure.
But it's interesting, in some languages you say, I feel that I have failed. In other languages, I feel like a failure. And in some languages, you can't say it at all. That, very often in Spanish, I hear, yo pienso, not, and I think I'm a failure. Is that correct? Would that be correct to say it that way?
Yes, actually, I think an Italian client would say, I am not a feel.
So the whole idea, I feel as if things will never get any better, is in many ways an artifact of language and not one's affective state.
So we want to be really careful.
Yeah, like I feel worthless, I feel incompetent, I feel inadequate. Those are all thoughts. And when you think that, you feel something.
I have a question.
Yeah.
Kristene, really, speaking of semantics, we were going back and forth between like failure and failing.
Mm-hmm.
How important is it for you to like get your patients on the same page in terms of like what word definitions are? Because I have issues with that sometimes.
Personally, it's very important to me. I'm not here to change their language, but I'm here to explain what it is and get them to start to watch their language.
Mm-hmm.
So I do spend a lot of time. It's not always direct. I might just casually change what they say. Like I can't do well. You haven't been able to yet. Or how would you define failure, incompetent? It's very important because that's usually the rope that I give them to hang themselves. When they start to tell me what a failure is and start to define, or a bad parent, they give me the definition, and then I just throw back. So you meet this criteria, they typically do not. So
Okay.
I do spend time on semantics.
Okay. So, this was a really interesting, I was kind of worried that maybe we left too much time for discussion, but that's not the case, and I want to let's thank Andy. I think it's always brave to put your professional work up for your peers to examine, so let's thank Kristene.
Let's thank Ray for putting this together.